Absolutely life saving.
The use of the influence.
So with that, I'm going to turn it over to Chance.
The other's dream.
All right. Good morning,
Everybody
everyone.
mute yourself if you're not Chance.
No.
Mute yourself.
Yours is obvious too.
All right. Good morning, everyone. I'm going to go ahead and share my screen here so I can pull up my PowerPoint. Let's see here. Can everyone see that? Good. Excellent. So as Mary said, my name is Chance Littrell. I am the director of the Zero Suicide Initiative program with Mental Health America of the Mid-South. What we're going to be talking about today is a little bit just about the ZSI initiative in and of itself, some of the founding principles and beliefs of that initiative. And of course, we'll hear from both Sabrina and Sarah about their experiences in implementing ZSI at their locations. And then we'll have a Q&A where you can, ask questions about implementation or the model itself, anything that, might come up for you throughout the presentation. So we'll go ahead and get started here. We know that people at risk for suicide are being seen in mental health care settings, right? Be it primary care, emergency departments, or behavioral health settings. And the research tells us that these individuals often see a healthcare provider in the weeks leading up to a suicide attempt. Now, if you'll notice the data here, in the month before their death by suicide, about half of these individuals saw a general practitioner and approximately 30% saw a mental health professional. Now, many of these people were seen in emergency room departments shortly before their death as well. And in spite of this point of contact with various healthcare systems, these individuals still go on to die by suicide, often because no one asks those critical questions or attempts to intervene. Healthcare professionals often fail to ask about suicide risk, either because they weren't trained to, they don't know how to recognize suicide warning signs or risk factors, they don't know what to do if someone is at risk for suicide, or perhaps they even believe erroneously that the person at risk would just tell them if they're feeling this way. And the idea here is that if we can improve suicide identification and suicide safe care in primary care settings where most people go for their treatment, or in emergency rooms where most people go when they are actually experiencing a suicidal crisis, we would have the potential to save just an unfathomable number of lives. And in order to do this, we need a comprehensive approach to identifying and managing that suicide risk within these systems. And that's really what the Zero Suicide Initiative is all about here. So here we have a quote from Dr. Mike Hogan, who is with the New York Office of Mental Health. Suicide represents a worst case failure in mental health care. We must work to make it a never event in our programs and systems of care. And again, we know that suicide is the #1 most preventable cause of death, but in order to prevent it, we have to know what to look for, and we have to know how to intervene successfully. And we largely do a poor job of this in spite of the accessibility for these resources and materials. Now, the responsibility for suicide identification and treatment, at least historically, has been placed upon the mental health system and mental health care providers in general. Other healthcare providers and family members who may be concerned about a loved one who is experiencing suicidal ideation often refer those at risk for suicide to a behavioral health care provider or a mental health clinician with the understanding, right, with the belief that they're going to get effective care. What's most concerning here to me is that many mental health care providers have never been trained explicitly in suicide safe care, even though they may be licensed clinicians. And if you look at this data here, 39% of licensed clinicians that were surveyed here report that they do not have the skills to successfully engage and assist those at risk for suicide. And 44% report that they do not feel they have adequate training for assessing and managing suicide risk. Now, the field of suicide prevention and suicide safe care in general has grown tremendously over the last 5 to 10 years. Evidence-based clinical assessments and treatment tools are readily available, and the use of these approaches are something that we're striving to make the standard of care rather than just the aspirational goal. But we know that this type of system-wide change, I mean, we're talking about transforming the very way that we approach care, essentially. We know that this type of change is often slow and met with resistance. So there has to be some flexibility there with implementation. And that's something that I think that Sarah and Sabrina will both be able to speak to a little bit here shortly. Now, here we have another quote by Dr. Richard McCown. Over the decades, individual mental health clinicians have made heroic efforts to save lives, but systems of care have done very little. And I think this is a great point here, in that the burden of assisting and caring for those who are at risk for suicide has often fallen to the individual, the person, the therapist, right? The clinical social worker, whoever that may be, the individual clinician, rather than the actual system of care in which that clinician is operating. And one of the big things that we're striving for with this initiative is taking that burden off of the individual clinician and making suicide safe care the responsibility of the entire organization. From the first point of contact to the discharge planner, everyone has the knowledge, everyone has the skills, everyone has the tools at their disposal to both identify and manage that suicide risk, in helping to, like I said, just raise that standard of care that much higher. Now, suicide deaths for people under care are preventable. We know this. The zero suicide approach aims to improve care and outcomes for individuals at risk of suicide in these healthcare systems. Now, I understand, right, that when you hear zero suicide and we're talking about the goal of reducing suicides to zero, that seems largely aspirational. But then the question that follows from that is, what's an acceptable number of suicides? Zero has to be the goal that we're working towards. And several healthcare systems have already implemented this approach, and they've seen significant reduction in suicides among their patient populations, with rates of suicide being reduced by as much as 70 to 80%. Now, if you think about that and you put it into context of like our statewide suicide rates, for example, over the last couple of years, we've been, give or take a little bit, around 48,000 suicide deaths in Tennessee. Now, imagine if we were able to reduce that across the board by 70 to 80%. We're talking about saving thousands upon thousands of lives. And that's really what we're working towards here. The Zero Suicide Initiative, of course, is also a priority of the National Action Alliance for Suicide Prevention. It emphasizes the need to transform healthcare for those at risk for suicide through a focus on safety and error reduction. So there is a lot of monitoring and evaluation that takes place as well as through the use of best practices in suicide care by healthcare systems and the providers within those systems. Now, another quote here by Thomas Priscilla. I apologize for butchering his name. It is critically important to design for zero, even when it may not be theoretically possible. It's about purposefully aiming for a higher level of care. So like I've said, and you'll hear me say it again, I'm sure, we're aiming to improve the overall standard of suicide safe care. We know that suicide risk exists for a great number of Americans day in and day out. We know that these tools are available. We know that they're accessible, but the care as it stands right now falls short in that regard. Suicide, I think largely for many organizations, unfortunately, is checking a box, right? Are you experiencing suicidal ideation? No, boom, on and onwards and upwards, right? We move on. It's just one thing that we check. And whereas that is better than doing nothing, there are a lot of things that we can do to improve upon that and make sure that we're really assessing properly and then managing that risk when we identify those who are at elevated risk. So the Zero Suicide Framework represents the opportunity to use better evidence-based approaches to suicide care that, again, are readily available, highly effective, and have been shown to stop people at risk of suicide from falling through the cracks in the healthcare system. Now, closing that gap, like I said, takes a comprehensive system-wide approach. And all of the following here are considered to be essential elements to that approach. And they're things that must be included if we are implementing the ZSI model with fidelity. So we must have a leadership-driven, safety-oriented culture that includes suicide attempt and loss survivors in critical roles. So we say suicide attempt and loss survivors because that input from people who have been in that space and truly understand the needs of a person who's experiencing suicidal ideation really help to inform the kind of care that we're providing. We're not just, taking the research in and of itself and using that to inform. We're taking the actual input from people who have been in those shoes, people who have attempted suicide, people who have lost loved ones, or people that are close to them by suicide as well. And we do consider that to be a critically important piece here. We must have a competent, confident, and caring workforce where suicide care, again, is not just relegated to the clinical staff, but it is the responsibility of everyone within the organization and every single staff member, regardless of their role, regardless of how much direct contact they may have with patients or clients, view suicide safe care as a priority. It's something that is embedded in the very culture of the organization. We must use standardized evidence-based tools to identify and assess suicide risk among people receiving care. And we need to ask about suicide at every single visit for those individuals that we identify as being at risk. Now, every person at risk for suicide, according to the ZSI model, should have a suicide care management plan. Care should include collaborative safety planning and restriction of lethal means when patients have known risk for suicide. We really strive to engage the person at risk, explaining the importance of treatment and following up immediately with them if they miss a scheduled appointment. Just leaving a message or sending an email isn't really enough to protect or keep someone who's at risk safe in those instances. And the big thing here that I truly value about the ZSI model is this collaborative piece. We're not just telling the person who's at risk for suicide, here's what we're doing. We're engaging in that discussion with them and having them help us inform what they need to stay safe in those situations. Now, we must use effective evidence-based treatments that directly target suicidality. Short-term actions to keep people safe, like hospitalizations, aren't really a substitute for ongoing concern or for the need for better treatment from outpatient providers, mental health providers, whatever the case may be, because generally the problem doesn't disappear after a short-term hospitalization. And I know that that's often our go-to, right? When someone's experiencing a suicidal crisis, we get them hospitalized. They're there for 72 hours-ish for most people, and then they're discharged. Suicidal ideation can't be effectively treated in 72 hours. They may be in a better place. That crisis may have de-escalated a fair degree, but that long-term treatment, that long-term care, that long-term support is of critical importance here. And that's one of the things that the ZSI model really addresses as well. Now, I've kind of touched on this already, but we must provide continuous contact and support for those at risk, especially after discharge from acute care settings. There needs to be ongoing communication from healthcare staff during times of transition, brief supportive contacts such as phone calls, texts, even home visits when necessary are some of the most proven and powerful suicide prevention interventions. Now, if you think about this within like the suicide context, right? One of the biggest things with suicide, as far as warning signs are concerned, are people who are feeling disconnected and people who are feeling isolated. If we're talking about little things, phone calls, text messages, just checking in, hey, how are you doing? I haven't heard from you in a couple of days. That little bitty thing to us can be absolutely huge to a person who's struggling with that feeling of isolation or disconnection. So that's something that we really want to prioritize as well. Now, finally, we should track our efforts in these dimensions and use data to continuously improve our approach. For an organization to truly establish, right, meaningful change and comprehensive suicide care, policies, training, guidelines, all of these things need to be in place to support those dimensions and the dedication to that mission. So that's something that we're currently in the process of. Sabrina and Sarah may touch on this a little bit, but there is a big evaluation piece, especially early on in implementation, because we want to know where the leadership is at. We want to know where the workforce is at with regards to not only their knowledge about suicide safe care, but their comfort levels, their competence, all of these things, because the next step and where we're at in implementation with both Helping Hands and Friends in Need is building a tailored, essentially, treatment plan. We call it a work plan, but building a tailored plan based upon those needs we identified through the assessment and evaluation piece to help them improve in regards to suicide safe care. Now, the comprehensive zero suicide approach fills those gaps in healthcare that I touched on earlier that allow people to fall through the cracks and unfortunately go on to die by suicide. Now, in closing, most healthcare systems are not optimally providing suicide safe care for those at risk. However, these settings, right, primary care, emergency departments, behavioral health care settings are ideally positioned to help prevent suicides. Many screening, assessment, and intervention tools have been developed and tested within the last 10 years, and are readily available. They're easy to implement, they're easy to train on. And zero suicide makes these tools available and allows for support and guidance throughout that implementation process. Now, primary health and behavioral health organizations have successfully implemented all of these elements of zero suicide that I just touched on, demonstrating that the approach is not only feasible, but it's also practical. Patient safety and suicide care, at least from my perspective, has to be a priority for our healthcare organizations. And we should strive for nothing less than zero suicides for those who are coming to us for help. And that's kind of my piece there. So I guess I will turn it over to Sarah or Sabrina, Mary, if that's cool with you, and then we can do a Q&A after. All right, so I'm going to stop sharing my screen, and then Sarah or Sabrina, if one of you want to jump on.
I'll be happy to start if that's okay with you, Ms. Sarah. Well, I guess she says yes. Hello, everyone. Good morning. I just kind of wanted to share about our experience and the reason why I was motivated to get started. It was an absolute no-brainer for me. We had a patient upon me answering the phone one day a couple of years ago and stated that had I not answered the phone, she wanted to commit suicide. And she felt like just by me answering the phone gave her hope. And that was my light bulb moment to know that it was extremely important that we implement this program. And so when the opportunity came, I jumped all over it because it touched my heart that some woman would reach out to me and even say that. But my relationship in working with Chance and working with Mental Health America has just been extremely positive. It hasn't been overwhelming for me because Chance and the team have really kind of customized it around my schedule. And there's been a lot of changes at Helping Hands of Tennessee with staffing. So there's been a lot of adjustments that they have been able to work with us so that we're not under major pressure to get things done today, because that would have been impossible for us. And so as it relates to most clinics, I mean, it's helpful to know that, you know, they're willing to work along with our schedules and with our workflows and modify things accordingly. But like Chance had mentioned earlier, we started with an evaluation of our clinic to see, you know, what our employees thought. about suicide and what they thought more important about the protocols that Helping Hands of Tennessee had already had in place. And there's a lot of areas of opportunities, as I would call it. With that being said, the reports were shared with us. And let me back up to that. They not only wanted to hear from the staffing, but they also wanted to hear from the management team. So collectively, they wanted to know, and that way they can compare to what is the manager's thinking versus what the team has come up with themselves, which is, actually it was pretty much aligned with where we're at. So we were able to give honest feedback and know that we have to have a case management plan in place. And that is what they're working on with us now, along with workforce development and making sure that our teammates are all on the same page and we all know what to do, know how to do it, and better help our patients. And that's extremely important, that customized plan based upon the evaluation. I do know we have the QPR training that's coming up for our staff. So that will, that's just another reinforcement that we need here at our clinic. That's a part of our case management. And so I think holistically for us, number one, it's important to me. I get it. And I'm glad that I do. And I know that my team gets it as well. So I'm a huge advocate for us implementing this. And again, I can't express it enough, just the fact that they're willing to work along with our schedule so that we're not overwhelmed by new policies and procedures, and making sure our team fully understand and can digest the information.
Thank you. We'll come back around for questions. Sarah disappeared off my screen. There you are. You moved to the corner.
I'm here.
Sarah, hi. There you are.
You scared me there for a minute.
Where's Sarah? You scared me. Go ahead. Let's hear from you, and then we can open it up. I have some questions. I'm sure others do as well.
Well, I'm sure you'll have questions, and it's a good thing to have those. Just a second. I'm having a moment in my life. I'm learning. Possibly. If not, we'll just go ahead without it. It just doesn't bother me.
Miss Sarah, do you mind if I say one other thing?
You go right ahead.
One thing too that I failed to mention is that we were sent the standard risk assessment, and our social worker extern student has been able to use that. Now she's gone for at this time now and come back next month, and we'll have another social worker student. So some of the things that that evaluation brought out is a proper way to screen our patients. And so they have all the tools and resources that's needed to make our lives a lot easier so that we don't have to reinvent the wheel.
Thank you. And Sarah, what are you struggling with? We can see and hear you fine. You have your slides, because Renee can put those up for you. If you want
I've got it on there. I hope and pray that. Can you see the slides now? I'm just trying to get share.
Not yet, but.
You're a co-host, Sarah, so you should be able to share using the green button as usual.
Do you happen to have her slides, Renee?
No, I should have done that, but it's okay.
It's okay.
We can do without it.
I know, I couldn't get my video on. It's rough out here.
Okay, let's just go ahead without that part. If I can find where to go back to you.
You're on. You're good. We can see and hear you fine.
Okay, good, because I can't see anything.
Oh.
All right, I guess the experience here, I've been looking for this for all of my life, believe it or not. The last two doctors that I worked for were in Virginia, and I was helping them to go ahead and set up in order to be able to take insurance, and it was for drug and alcohol rehab physicians. And I'm the social worker, and so we set it up the way that they would come in and be triaged and then right straight into my office. And I had two lists of questions that I would go through with every single one. I would begin that with the fact that I've been homeless 9 times in 10 years. There's nothing that I haven't seen or heard or done. So you can know that you can have trust with me. It will not go any further. But some of the things we're going to talk about today, we may have to seek further help. So I always made sure that they understood that. And I made sure that I asked questions that they fully could understand. I asked them, are you having thoughts of suicide? I did every day of my life. And they would just look at me with these big shocks, and then tears began to flow, that it's all right to be able to admit the fact that having those is very, very difficult. I was homeless 9 times 10 years, and during that time with 4 children. And so, yes, you get to the point where dying would be so much easier than having to go through that. Some of the issues that I had to deal with that brought about that, even as a child, was the fact that I was abused sexually. I lived in a horrible, horrible situation where everybody was dominant over me. So I couldn't even say no or, have any way to be able to protect myself. And that was the sad part. So thinking about death started when I was young. It started because also familiarity with, that's all you ever heard. I'm going to kill myself. I'm going to kill you. Those words, were constant in the mouth because it was always a dysfunctional emergency type life. And that is not what I wanted for my family. But unfortunately, there was a touch of that. It was hidden from them, but we were in the same household, and children still feel that. So some of the things, that's where my learning actually came from for suicide prevention. What did I want to do with that education that I received? Well, I had attempted suicide several times as a young person, and one of them I knew immediately to never do. I told someone, my ex-husband, that I had taken pills. He said, good, I hope you die, and walked out on me. So I learned that is not a good way to handle that. And then in talking and learning from Chance and from going to the training, which I absolutely loved, has just set my heart on fire. I love this. And the reason is, who is that neighbor? And I want you to know something. I'm a minister also and a social worker. But the thing of it that I look at is, the Good Samaritan story. Well, I worked for Good Samaritan Ministries for 21 years. That story is very dear to my heart. But I've taken that for the fullness now. Who is my neighbor? Everyone is my neighbor. I am to care about every single one that comes before me. I want to know, are you hurting inside? Because most of my life, I hurt inside with nobody knowing about it. I didn't tell my doctor. I'd go to my doctor and sit there and we'd talk about all the other things in life. And usually he just send me back out the door. Never asked me, are you having depression, sad feelings? And so when I got into it, I actually went into all of my patients. I went, are you having sad days that are really, really burdensome? Is it deeper today? What would you call that? And we would sit there, and I had an hour with each patient to go through to be able to assess that. And then I was surprised by a few of them, of, yes, I've attempted suicide 8 times now. Have you talked with a doctor about that? No, I haven't. He doesn't know anything. So this gave me a good leg up that in between the patients, I would place the patient in the next room for the provider, then run to the provider and say, I need to speak with you for just a moment, and allow them to know everything I had just heard. So when the provider went in, with new knowledge and education and able to help get those needs taken care of. And many of them, we had to take them on to the hospital. So when I came here, to be honest, this is one of my greatest outreach was I want to make sure that my staff understands the importance of suicide. And when I first asked, I'm going to be really honest with you, as I have been with them, I was very disappointed. Disappointed in the fact that I got answers like, well, yes, in school we had that and we did this and we know the forms, and that's not what I was asking. What I'm asking is, do you ask every patient that comes through here, these important questions, being honest, seeing where their mental health is, because if we're primary care, mental health, they have to be able to have both. And then to be able, even in our dentistry side, you're under the care and you're laying there. I want that provider saying, hey, how are you getting along? I know you can't talk to me now, but I want to tell you about a program we have here. If there's any issues you want to talk about, we'll get you back to see the next person before you leave today. And I want to make sure that everybody, before they leave this office, is aware that there's someone going to talk to them and help them to get where they need to go. I know that I called Mary and I was so excited. When you see a life saved, that is overwhelming. But the very first week, we had a young lady, 22 years old, that came in for her visit that day. And so I had talked with our young lady here that was with Project Access, and, she'd already taken the training as the rest of my staff did for the medical side. And they went in and she came in my office just bawling. She said, this lady is 22 and she's going to kill herself. She's already done, attempted multiple times. And I said, well, let's see what we can do, what needs to be done right now. This was our training, because we called the hotline and nobody answered. We, couldn't get medical records, where we needed them. We called the crisis intervention and we got someone and they interviewed, wanted to admit, but I couldn't get those papers. Nothing would come through the fax lines. And then we finally had to have someone go pick those up and bring them to us. And at 9 o'clock that night, we finally got her to help, but we didn't leave her. We wouldn't let her leave us. We called her mother to come in. And guess what? It's multi-generational, just like in my household. Some of the things that really hurt was that 2 of my family members actually succeeded. So having this 22-year-old girl say, thank you. I appreciate the fact that you took all that time with me, and I'm going to go get the help that I truly need. She had a plan. She already had practiced, and she was ready to roll. And so in my family, I had a veteran. Now, who do we think is going to take their lives? Well, I worked 21 years with my veterans. And so, and I didn't see it with him. I talked to him the night before. I didn't catch a tone difference, nothing. And I lost my Vietnam veteran and one of my dearest friends. And then a cousin who was only 18 years old had a fight with his girlfriend. And they came to my Christmas party for indigent children, and they did every year, he did. And they would pass out the gifts. And that year, I saw them off sort of arguing. And when that happened, I went in and wanted to know what is going on. And I talked to the daddy and I said, there's something serious there. 2 weeks later, he took his life. He didn't talk to anyone. No one knew. He went in, shot and killed himself. So now, who's your neighbor? Who's your family? Everybody that comes into your path, we have got to stop and realize, in this clinic in particular, everybody that passes through, I want those hard questions. I want everybody to care about that, be thinking about it as soon as they walk in. First time, brand new, I don't care. Every single time they come, how are you doing? What you thinking about? How are you feeling? And that's why, this project has been so dear to my heart. Chance has just been wonderful. Again, he's comfortable and peaceful, and that's good for me because I am on a constant little wheel here. And to be able to have someone to say, it's all right, we're going to work with this together. Making sure, one of the things that I never thought of, and then I'll shut up, it's really important to me, getting your policies and procedures. We did those last year and we did them all again this year because we've missed so much and things are changing daily. You really need to look at those. If someone does come in, what are you going to do? Who do we call? So I went out to the agencies that deal in this area and picked up all their information, made my contacts. Who do I call? If I can't get you, who do I call? And then now we have that, and then a plan. And then we keep them with us, lovingly, caringly, not in a room by themselves. Someone sits and talks with them and cares for them until we can get them to safety hands. So getting to know that and being able to say, Chance, what did I do right? What did I do wrong? How can I do better? I love this with all of my heart. This is who I am. I feel like every time, and that lady, and then, you know, the next day, another lady came in. Her daughter brought her in, same thing. And we got help for those two immediately. And in watching that, that says, that was for you. That was for you. And that was for you. Everybody that we can save and get to that mental health and have that happy future in their life, it does change. I don't have those thoughts anymore. But I know one thing I've learned from them, and other people do. Ask them. Please ask those questions.
Sarah, thank you.
Questions?
I
Oh,
just
one
want to
other
say
thing
thank you. Go ahead. Go ahead.
On these special populations is where my heart has really turned. I feel like we're really leaving here in our area, leaving them behind. My dear friend who I went to school with, and we ministered together, and we did missions in Mexico. And every time I go, he's my interpreter, but I felt just about as isolated as you could be, because if he wasn't present, I couldn't talk, I couldn't communicate. So that helps me to know how they're feeling here. And they can't communicate, and they want to, and they look at you in such fear. So fear and isolation, language barriers. Actually, that all helps to bring the depression. Also, drug and alcohol use. You have to remember a lot of this is tradition and through religion. And so we are hiring him right after the first of the year, and he's going to be interviewing all of my Hispanic families, including our new program, Working with Children, so that we are getting from them, how are you feeling? What has COVID done to the families? Actually, the pastor I told you about, his mother, when we were at the conference, his mother died the week before from COVID. And the reason was the family would not take her to the doctor, because one of the boys said, if we take her to the doctor, they're going to give her medicine that will kill her immediately because of trying to control the population. They really believe that. And now he's left with that horrible thought in his mind, and that they did not get the help they needed for his mother. So this is where we're going next. It's a big step, but I want to be able to reach out to our communities that are here from different countries and be able to put people that can communicate and can put those arms around and say, let's go get help.
Sarah, I just want to say you're so courageous. I am so grateful for your courage. You know, I'm not from an easy past myself, and it's hard to say the truth about where you're coming from, but there's nothing that connects a person safely to you more than knowing, I know pain, like I know what pain is. I know what suffering is. I know what joy is, and I know what hope is. And I'm going to, be with you. So I love the example both of you set. I have to say, it kind of broke my heart when TCCN was invited to do Zero Suicide Initiative. It hurt my heart. We were invited along with, Chance is going to have to help me now, Core Civic. Can you run
Yes,
through the people that were invited?
absolutely.
With us?
So TCCN, Core Civic, WellPath, the Refuge Center for Counseling, and then I'm forgetting someone. I feel terrible about it. Sparrow Health and HCA.
Right. And so we were invited in by Mental Health America, a partner. TCCN lives through its partnerships. Our partners are our blood, our life force. And we were invited in with these heavy hitters. We were in there with HCA and Core Civic. And I thought, oh, my members understand that, there is no health without mental health. We always talk about it. We all understand it. But so I thought I'd get more than two. And actually, it's been fine that I only got two, because I got to really see how two of the busiest people I've ever met, who are never sitting still, who are constantly growing services, who don't have an extra moment for anything made time, but they also received, very supportive approach. This program meets you where you are. There was never, you didn't do what we said on the time frame we said, none of that. That's not how this program works. But I just think you two are courageous. I want to see more courageous members because there's no healthcare without mental health, right? What good is it if you have a whole new set of teeth if you want to go shoot yourself, right? Where are we here? So I'll be quiet. I wanted to thank you both. You're both courageous and incredible leaders. And to make sure that the audience knows, TCCN was invited in to a pretty cool group of people. And only 2 of us showed up, but Chance, how many other folks are there participating this round that we've got going?
You mean how many locations are we working with in total?
Yeah, how
So-
many locations are participating through Core
So-
Civic or?
Number of locations total right now, we are at 58 different locations.
And so that's a lot of people that are learning. And so I'm really going to keep encouraging you guys, I can't let it go. I'm a dog with a bone. It matters. Okay, so
So
about
I will
the-
say, I'll echo what Mary said there, and that Sabrina and Sarah both appreciate you sharing both about your personal experiences, but also about what implementation has looked like for both of your respective locations. And again, like Mary touched on, I know zero suicide, when you look at those core components, it seems like a lot. And it is a lot, in all honesty, but we have so much flexibility in implementation that it doesn't feel like a lot, if that makes sense. But 2, like, I think through that evaluation process, a lot of agencies and a lot of locations are in a better starting position than I think they anticipated they would be. And we build off of that. We build off of those strengths and we identify those areas for improvement, and we start to build those up into strengths as well. So it is really adaptive and really flexible in that way. Now, I guess kind of jumping into questions here, one of the things that popped up in the chat was to define QPR, which I know Sabrina had mentioned. So QPR is an intervention model. It's one of the trainings that we provide as a function of zero suicide. It stands for question, persuade, refer. It's really like our introductory level suicide intervention model. So the big piece here is about getting comfortable with asking uncomfortable questions. Because if you think about suicide within like our societal context, right? It's something that is still very much taboo. It's something that is still very much stigmatized. So just getting to a place where you're comfortable asking someone about suicide in a direct and upfront manner, and then knowing how to respond appropriately if that answer is yes, I'm thinking about suicide, is really what QPR is all about. So asking the question, hearing that person share a little bit about their experiences and what's going on, talking with them and ultimately persuading them to get help, and then referring out to the appropriate level of care, the appropriate type of provider. And like I said, that's kind of like our entry level training. We can do that in an hour to 2 hours, depending on if we want to implement role plays in addition to the basic training. But we also have several other trainings that we offer that are a bit more intensive. Yeah. Any other questions or
Huge
anything
array
that
of trainings, right? Chance, there's just whatever your needs assess as,
Mhm.
they put a plan together specific to your program, to your staff, to your needs. And this is an international program, isn't it, Chance?
Yes,
So, I mean, this
zero
is
suicide is everywhere.
it's a movement, and it's a little, it's hard to see that we're having the impact we want to have because we hear about the increase in suicide, particularly as a result of COVID and more isolation. And, this is a tough time, but how great to be able to equip yourself. I mean, it was actually Tom Starling, who's the head of MHA Mid-South, who taught me how to say, I mean, he did it just in a little presentation. He goes, how many of you feel comfortable saying, are you feeling like hurting yourself today? Do you think you might want to hurt? I've had those thoughts, I've had bad days where I thought, I don't think I want to do this anymore. And Tom just kind of like, he just did it in front of like 100 people. And I was like, dude, I could do that. Thank you, Tom. So it's not as hard as you think, but it takes a little learning and a little scripting, a little hand holding, especially if you're not personally familiar with a high level of suffering. And you're scared of what that will mean. I mean, it's very hard to frighten me because I've looked at so many frightful things, as I know many of you have. It's a hard life, but they're here for our deepening and our teaching. So what are we to do? How do we respond? Who is my brother? Who is my neighbor? Who am I? So you all ask questions, jump in. Lynn, Deborah, Anita, Randall, Helen, Cindy, Judy, Danny. Anybody have questions for anybody on the panel? What a way to stun people into silence. Say their names out loud. You're supposed to wait for 30 seconds. That's so hard to do. All right, so how many of you are going to sign up and why aren't you going to sign up? All right, that's the question. Why aren't you signing up? And they did this while they were doing Project Finish Line. Both of you are Project Finish Line participants. During this time, Sabrina opened up a medical clinic on top of her dentistry clinic and started a university inside of her program. Sarah, as she said, has started this whole new ministry around being able to speak directly to people who don't speak English. And I don't know what all else. It's screening children, and children are at high risk. People don't realize how early the thought of, I would rather die than do this comes up. So I know most of our members are screening people, are working with people, 18 to 64. But when you're talking to somebody who's feeling sad, you might also say, well, how's it going with your kids? I mean, it's a family event, isn't it?
Well, and Mary, just to kind of build off of that, for example, one of the partners that I work directly with is the Refuge Center for Counseling down in Franklin, Tennessee. And of course, they serve the entire age range. So they work with a lot of kids and adolescents as well. And we approach that similarly. We just kind of break things into two levels. So we may, like Sarah said, be working on protocols and policies and procedures for working with adults and, setting specific assessment and screening tools for working with adult populations, and then do the exact same thing for working with kids and adolescents. Because whereas the themes and a lot of the basic workflows are going to be the same, some of the tools that we would want to utilize are a little different because, kids are faced with a lot of different stressors now than they were arguably when any of us were, down in middle school or whatever the case may be. And their needs are a little bit different. So again, just kind of that flexibility in the way that we're implementing, to target specifically the populations that you are working with.
That's helpful. Okay, well, I won't make you, I'll give you back 9 minutes of your life if you don't want to talk. Think about it. Oh, go ahead. Oh, wait.
Yes.
Renee,
I'm gonna
have
share.
slides.
I'm going to share my screen one more time.
Go ahead, Unger.
So we just wanted to share some upcoming events. Oh, I went too far. Okay. We just wanted to share some upcoming events with you all. We are trying to standardize our monthly meetings. So hopefully we can keep bringing you great content and information and things that are helpful to you, just like we did today. Thank you so much, Chance and Sabrina and Sarah, for sharing. So we have another one coming up January 21st with Unite Us, February 18th with the Alzheimer's Association. We scheduled our Hill Day for March 9th. And Mary, remind me who we're doing that in conjunction with?
Well, who will also be there? Actually, we're sponsored by Senator Yarborough, to be there. But our Rural Health Association of Tennessee will be there that same day. So that'll be fun for us to be able to connect with them as well. It's always a great event. we're going to be hitting you with some advocacy trainings here pretty quick because they're starting to get the session rolling. So we're excited about that. And you're on a roll. Go ahead, Renee. Tell them about the spring
Sure.
conference.
Sure. So our spring conference this year is in Memphis. It is the last Wednesday, Thursday, Friday of March, and that Friday is actually going to be April 1st. And we are really excited to be hosting everybody. And I've been looking at the lineup, and it's coming along really nicely.
Wonderful. And TCCN is hoping to be able to pay for members to come and participate in this event in Memphis, pay for your hotel, food, and registration. That's our hope. We're working towards that. We know that finances are a burden, and so we're thinking we might have a way to do that. So stay tuned. And there was a question in the chat about getting an attendance certificate, which is a great idea, certificate of attendance. Let's take it back to Annabelle because she is the knower of everything important that's operational. And we will make that happen for you, Judy, and anybody else who wants one. So, okay.
And just a final note here, Mary, I did include my email address in the chat. If you think of any questions after the fact, please don't hesitate to reach out. I'm always happy to be a support in any way that I can.
Appreciate you, Chance. Appreciate you all. Thank you for the work you're doing.
Thank you.
Yeah.
Thanks.
Thank
Have a
you.
good day.
Bye-bye.
Bye, everybody.